So welcome to this Med Crash course session on ophthalmology. We've got our link to the Instagram page on the top right hand side, so please do join, and then you'll hear about all our upcoming events as well. And then on the left at the bottom is our email address, so if you have any questions about the session, if you're watching afterwards or watching now, feel free to email us and we'll try and get back to you. So this is the link to the polls, so if you can scan the QR code, and I'll just start the session. Quick refresh. There we go, should have started now. And just, yeah, feel free to vote as we go through. So today's session is on ophthalmology. The first lecture I had about ophthalmology, they told me the main thing you need to know about ophthalmology is that it has an extra H in the name, which has actually served me quite well. If you spell ophthalmology right, people are quite impressed. And I'm Anea, so I'm an F2 at Frimley Park, and I did my undergrad at St George's and then did my F1 at St George's as well, and now I'm in GP in Frimley. So just a disclaimer about all the information from the presentation today. So all the information in this presentation I've taken from kind of textbooks and lots of different online resources. None of the images are my own, they're all from kind of Google. And just for future, when you're working, just make sure you always check your local guidelines and don't by any means use my slides to make your clinical decisions, which I'm still sure you would check your guidelines anyway, but just to say. All right, so we're going to start with our first SBA. So which structure is responsible for changing the shape of the lens? Is it A, the ocular papillary muscles, B, the trabecular meshwork, C, the ciliary body, D, iris sphincter muscle, or E, the dilator pupillae? I'll give it 5 more seconds for people to think about. Perfect. So the answer is C. So well done. The answer is the ciliary body. So just to run through a little bit of eye anatomy, it's kind of one you just have to sit and learn yourself, really, like with all anatomy. But the anterior chamber is made up of the kind of area between the cornea and the iris, and then the posterior chamber is between the iris and the lens. And that's kind of one that they might ask you questions on. And then there are 3 kind of layers of the eye. So you've got the fibrous layer on the outside, and that includes the cornea at the front and then the sclera. You've got the avascular layer, which is your kind of choroid, and also includes kind of the stroma of the ciliary body on the iris. And then you've got your retina, which is the pigmented layer that has all your kind of photosensitive kind of neurons and everything. And then you've kind of within your retina, you've got your macula, and that's responsible for kind of your central vision and all the kind of really sharp vision that you can see. And within the macula, you've got kind of a little dip, which is called the fovea. And your optic disc at the back is where your optic nerve leaves the eye, and that's where you get your blind spot. So we're going to start talking about some acute red eyes now. So we're going to start with another question. So what is the most common viral cause of conjunctivitis? So is it A, influenza, B, poliovirus, C, adenovirus, D, CMV, or E, herpes simplex? All right, we'll give it another 5 seconds. All right, final answers now. 5, 4, 3, 2, 1. Cool. The answer is actually adenovirus. You can get conjunctivitis caused by herpes simplex as well. The other ones, maybe you can, but definitely a lot less common. But adenovirus is kind of the most common one. So conjunctivitis is kind of inflammation of the conjunctiva. You can have kind of two main reasons for it. Either it's infective or it's allergic. And if it's infective, you need to give the patient advice about not hand washing and not sharing towels because it can be quite contagious. Viral, like we said, is most commonly caused by adenovirus. The main symptoms are you get this kind of gritty, watery eye. It's not usually painful and they don't usually get any kind of visual loss, but they can be a bit photophobic. Not usually photophobic. Can be, but not usually. And that would usually just self-resolve within a couple of weeks. And then you get your bacterial conjunctivitis, and the symptoms are very similar to viral conjunctivitis, but they usually complain of having this sticky eye, like in the picture. They get all this kind of secretions around the eye. It can be treated with chloramphenicol drops, but you don't really need to. So the general advice is not to, and that it will resolve by itself in 5 to 7 days. And then your allergic conjunctivitis, you get kind of watery eyes, you get kind of swelling of the eyes, they're a bit itchy. Kind of main differential for that would be if they have kind of other allergic type symptoms. So if they have hay fever, if it's worse at particular times of year, anything in particular that sets it off. And for that, you can give topical antihistamines. So next, SBA. A lady comes into clinic with a painful right eye. You see this on fluorescein staining. So what is the diagnosis? Is it going to be viral uveitis, corneal abrasion, herpes keratitis, bacterial keratitis, or bacterial uveitis? Give it another maybe 10 seconds. This one's quite a spot diagnosis. I think either you know it or you don't really. All right, I'm going to close the poll now. So the answer to this one is herpes keratitis. So these kind of green, they're called dendritic ulcers, and this is kind of very characteristic for herpes keratitis. Keratitis is inflammation of the cornea. It can be infective or non-infective. Kind of the non-infective cause is very commonly associated with contact lens wearing. And if you get something in your eye as well, that can cause corneal abrasions. But symptoms are you get a red, painful eyes, usually photophobic, and you can have some decrease in your visual acuity as well. And the most common cause of keratitis is herpes simplex. That's common infective cause. And yeah, that causes these dendritic ulcers. So fluorescein staining is when you just kind of put a couple of drops of this really orange stain in the eye, and then when you turn the lights off in the room and then you shine a light from the ophthalmoscope in the eye, any kind of scratches or abrasions on the layer of the cornea show up. And if you've got a keratitis, you want to refer it for a same-day ophthalmology assessment. So it's not something that you'd really be managing in primary care. And treatment for it is they're going to give some antiviral drops and also some steroid eye drops. But if it's really severe, rarely it can need a corneal transplant as well. So it's worth getting them seen by a specialist. And then uveitis, which was some of the other kind of options on the question. So the uvea is made up of the iris, the ciliary body, and the choroid. And people often get quite confused between kind of uveitis and iritis, and they're kind of used sometimes interchangeably. But iritis is kind of a type of uveitis. So iritis would fall under the category of anterior uveitis. And you can also get kind of an intermediate uveitis, which is where the vitreous is inflamed, posterior, which is where it's further back and it's either the retina or the choroid, or you can get panuveitis, where just the whole thing is inflamed. And the most common thing in SBAs, they'll probably link it to an autoimmune disorder. So something like IBD or sarcoid or Anky's-Bond, that would be kind of if that comes up in the question, that's kind of a flag for uveitis. Can also be caused by infection, trauma, and very rarely malignancy. So the symptoms, it can either be in one eye or can be both eyes. They'll have kind of pain or a dull ache. They can have red eyes, but not always. And their vision will be kind of blurry or reduced, have watery eyes, be quite photophobic, and they can sometimes see flashes or floaters. And some signs that make you think it's definitely uveitis, you can get, like this picture on the bottom left, you can get an unreactive pupil or distorted pupil, and that's caused by kind of when there's all the inflammation, the iris can actually get stuck to the lens, and mean that it can't move as it would. So that's kind of a classic sign, very rare. My dad's an optician and he says he's literally never seen it, but that's one at med school they love talking to us about. And you can also get kind of dots on the rear of the cornea, which are called keratic precipitates, and other adhesions from the iris to the lens, which are called posterior synechiae. I don't think they'd expect you to be able to spot that, but just worth knowing for theoretical reasons. And you can also get hypopyon, which is what is shown on the top left picture, and that's kind of this level of pus that you can see just behind the cornea, and that's a sign of kind of more bacterial infection. So again, like similar to keratitis, you should always refer cases of uveitis on to an ophthalmologist. Don't try and manage it yourself. To help treat it, you're going to give topical steroids, and they'll need dilating drops, so drops like cyclopentolate. You might give some antimicrobials as well if you think it's a bacterial infection, and if people are getting uveitis, you're going to want to investigate to see if they have an autoimmune disorder as well. All right, so next.
Sorry, just for uveitis, is the reason why it's the iris, the ciliary body, and the choroid because they're all on the same layer? Is that why it's an infection of that particular layer, or?
Yeah, I mean, I guess, yeah, they are kind of a continuation of the same layer. Yeah, I think so. Yeah, I would go with that because keratitis is kind of the layer in front because that's the cornea, and then you've got uveitis, which is kind of, well, includes most things further back really. So yeah, I think so. Sorry, that's not a definite answer, but yeah, I think.
No, that's okay. I'm just trying to, like, I guess, section it in my head and then think about it in terms of like anatomy of the eye, but it's fine.
Yeah, no, but it would be. I'd say if you're trying to section it in your head, do like keratitis further forward and uveitis anything further back, more than kind of the layers, I'd say. But yeah. All right, so next SBA. A 70-year-old lady attends your clinic with a severely painful left eye. She reports that she feels nauseous, she has a headache, and she can't see very well out of her left eye. The pain started suddenly after she went to the opticians and they put some drops in her eyes earlier that day. On examination, her left eye is watery, her cornea looks hazy. What other finding would you expect to find on examination? So is it a mid-constricted pupil, chemosis, hypopyon, fixed mid-dilated pupil, or a dendritic ulcer? Let me just open the poll for you. give you another 10 seconds. All right, gonna stop the poll now. All right, so the answer is actually D. So it's affixed mid-dilated pupil. And that's because when it's in the position of being mid-dilated, that's when you have the most contact between kind of the lens and the iris. So that's when it's most likely to kind of get stuck. SBA 5, so following on from the same question, you decide to start her on some treatment urgently. You decide to give her some oral acetazolamide. How does this drug work? So does it either pull the iris away from the trabecular meshwork? Does it stop fluid production in the trabecular meshwork? Does it pull the cornea away from the ciliary body? Or does it stop fluid production in the ciliary body? Or does it reduce blockage of the ciliary body? All right, I'm gonna stop the poll now. So the answer is D. So it stops the fluid production in the ciliary body. So all of these questions were kind of going towards acute glaucoma. And acute glaucoma is an emergency. It's more common in kind of middle-aged people, kind of older age patients, and East Asians as well. And it's caused by a sudden increase in the intraocular pressure due to a mechanical blockage of the trabecular meshwork by the iris. So usually your kind of fluid is made in your ciliary body, and then it kind of comes around into the anterior chamber, and then it flows out through the trabecular meshwork. But in acute glaucoma, you have the iris blocking that trabecular meshwork. So the fluid comes around, but it then can't drain out of the eye. So all of a sudden you're getting this kind of pressure build up. And it's usually caused by kind of an anatomical thing in the eye. So some people are just more prone to it. Some people just have a very, very small angle here. That means even if in the question I was referring to, it's kind of if opticians give dilating eye drops, sometimes they want to give dilating eye drops to take photographs at the back of the eye, or just look in the back of the eye properly. And some people have such a narrow angle here that if their iris kind of goes back towards that side, it can just kind of completely block that angle and cause glaucoma. So in terms of symptoms, they're going to have severe eye pain, watering of the eye, vision is going to be affected, and then they'll have a headache and nausea as well, and can vomit. So it's one of the few ones that makes them feel kind of more systemically not so good. And on examination, they're going to have a hazy cornea. That's because of kind of waterlogging of the cornea. So because you're not draining any of this fluid, it can kind of like waterlog the cornea, and that makes it look hazy. And then the fixed mid-dilated pupil is just one to kind of memorize, but that's just the point at which there's the most contact, so where it's most likely to get stuck. In terms of treatment, you're going to want to give them acetazolamide, and that turns off fluid production in the ciliary body, so helps reduce the pressure that way. You can also give pilocarpine, and that helps to pull the iris away from the trabecular meshwork. I don't know exactly how it does that, but I wouldn't worry about it, but that's how it works in theory. You can give ocular antihypertensives and steroids as well. and the definitive treatment is to use a laser and just make a hole in the iris that allows the fluid to drain out. So definitely, if you suspect it's acute glaucoma, always refer in, because it's all a bit beyond us if you're out of ophthalmology. So next section, I'm going to go on to acute loss of vision. So let me start the next poll. So a 68-year-old woman attends A&E. She describes having a headache and feeling generally unwell. She reports aching in her shoulders and in her neck. She tells you that brushing her hair is unbearable and that she thinks her vision in her right eye might be slightly worse than normal. So what would your first step in management be? Are you going to ask ophthalmology to assess her? Are you going to wait for their blood results to come back, including CRP and ESR? You're going to organise an urgent ultrasound scan of her temporal arteries. You're going to give a stat dose of oral prednisolone, or are you going to ask the stroke team to come and have a look at her? All right, I'll give you 10 more seconds. I think my 10 is actually 5, but cool. I reckon that's enough time. So the answer is D. So well done to everyone who thought D. This question is getting at that this sounds like a giant cell arteritis. And if you suspect that that's what it is, you should just treat them straight away and then investigate later. Because kind of the investigations aren't, firstly, they're not great for it. So ultrasounds are good, but it's going to take you a while to get an ultrasound. And you can do the temporal artery biopsies, but sometimes they'll miss the area of inflammation. So you shouldn't wait around for all those things. Just if you think it is, just give them some steroids. You should always consider it in anyone over 60 with kind of sudden visual loss, especially if they had a headache. The symptoms are this headache, they're particularly tender around the scalp, particularly around the temporal arteries. They might have some weight loss, some malaise. It's very linked to polymyalgia rheumatica, so they may well have aching, like in this case, aching in her shoulders, aching in her neck. At first, the visual loss may be intermittent and then progress, and then the other eye will usually be affected if you left it untreated. Within 48 hours, the other eye will start having symptoms, and they can also get kind of jaw claudication as well. So in terms of signs, you're going to have RAPD, you can have a pale and swollen looking disc, and you might even have kind of a pale ischemic looking retina. Like we said, for treatment, give them some steroids, and then you need to be really careful when you're weaning them off the steroids, because it can recur if you take them off too quickly. So you need to taper them really slowly. In terms of the investigations, the kind of raised ESR is something that we really heavily associate with GCA, but don't always rely on it because it's not always high. Platelets are often quite high. You can get the biopsy, but as I said, I wouldn't rely on it, and the ultrasound as well. So next, SBA. A gentleman comes into the clinic complaining of profound visual loss. When you look at the back of his eye, you see this. What is that indicative of? So is it A, diabetic retinopathy, B, CRAO, C, CRVO, D, a peripheral retinal arterial occlusion, or E, a vitreous hemorrhage? Right, give you 5 more seconds. Lots of mind changing, I can see. All right, gonna stop now. All right, so the answer is B. So it's a central retinal artery occlusion. I made up D. I don't think that's a thing that actually, well, it might exist. I don't think it does exist though. And yeah, so this is central retinal artery occlusions and central retinal vein occlusions. So in terms of symptoms, you're going to have someone who suddenly has kind of a profound loss of vision in one eye, and it's going to be painless. In terms of the arterial occlusions, it's usually due to an embolus, so either from the heart or from the carotids. And you can have transient arterial occlusions as well, and the fancy name for that is amaurosis fugax as well. So I'd memorise that because that does sometimes come up as an option in SBAs. So signs, you're going to have an RAPD and you're going to have this pale retina, and this sign in the question is called a cherry red spot, and it's just one of those kind of characteristic things for arterial occlusion. There's no proven treatment for an arterial occlusion, but it needs workup in stroke and TIA clinic. And in terms of the vein occlusions, so that's usually kind of more due to, yeah.
Just a question on the CRAO. In terms of transient CRAO, does that mean like it was like a temporary blockage?
Exactly, yeah. So it's like a retinal TIA basically. So it's just like it was blocked and then it's moved on, but the patient will come to you and be like, oh, I lost vision, and then it came back. But you still need to work it up because that suggests that they might have a clot somewhere else that's kind of embolizing, you know, losing fragments. So you still want to treat it quite seriously. Does that make sense?
Yeah, thank you.
Yeah, in terms of the vein occlusions, so they're very heavily associated with hypertension, diabetes, hypercoagulability, and kind of older age people. And in terms of what it looks like, it's this picture on the right. So it looks quite kind of horrible. But yeah, lots of different kind of hemorrhages and edema. And for that, you're going to want to treat with VEGF and retinal lasers as well. So next SBA, a 65-year-old diabetic gentleman attends A&E due to a sudden loss of vision in his left eye. He denies any pain. On examination, you notice that the red reflex is absent. What is the most likely diagnosis? Is that most likely to be a retinal detachment, diabetic retinopathy, a vitreous hemorrhage, a stroke, or a CRAO? All right, okay, 5 more seconds. Yeah, so the answer is C. It's a vitreous hemorrhage. For anyone who kind of would have been thinking A, it kind of could in theory be A, but it would have to be kind of a very specific spot. So it's kind of a lot less likely than C. And a vitreous hemorrhage is caused by bleeding from the retinal vessels into the vitreous gel. And it can occur secondary to trauma. If you've got like a proliferative retinopathy, so if you've got more kind of abnormal vessels in the eye, then it's more likely to happen. And it can occur secondary after a retinal tear or detachment as well. And patients are going to say they've got kind of a painless loss of vision in one eye. They might also not have complete loss, but just say it's quite blurry and hazy. Often they'll start by having kind of floaters or blobs in their vision, and occasionally some people do report seeing a red colour at the start, but I do think that's quite rare. And in terms of signs, you're going to have an absent red reflex, because when you kind of shine the light in the eye, you're not going to be able to kind of have the light bounce off the back of the eye, so that's why you don't get the red reflex. And also kind of similarly, the blood is going to be blocking your view of blocking your fundal view, so you'll go to look in their eye and all you're going to be seeing is this big blob of blood. In terms of investigations, you can do an ultrasound scan, mainly just to check that the retina is still intact and that there's not a tear. And in terms of treatment, it's usually going to clear up by itself in 6 to 8 weeks, but if not, then they might consider operating. So retinal detachments, if they're untreated, then kind of just a small tear can get fluid kind of behind it and cause the retina to kind of peel off from the back. So even if it's just a very small retinal tear, it does need treatment. So risk factors: people who are short-sighted, they're more likely to get it, just to do with kind of the anatomical shape of the eye. And then trauma as well is a common cause. And symptoms, the classic exam type question will be a curtain type loss of vision that progresses across the visual field over hours to days. So it's kind of as the tear is like progressing, the retina's detaching, they'll get this kind of curtain like loss of vision. It can be any direction, and it's all a bit confusing with the eye, because if you think about where the light rays come in, if you have kind of a detachment at the bottom, that's actually going to be affecting your upper field of vision because of the way the light rays come into the eye. So I think a lot of people, well, I always used to think of this as like a curtain coming down, but that's not, it can be any direction. And some people don't report that symptom anyway and just have kind of a sudden loss of vision. In terms of signs, they're going to have a field loss when you examine them, RAPD as well, and you can look in the back of the eye and see the detachment. And you need to get this seen urgently, because if it's not treated, then that eye can go blind and they're going to need surgery. So it's one of the serious ones to be careful of. And this is the third section of the talk now, so we're going to go on to chronic loss of vision. So the kind of most common one is cataracts. So cataracts are the most common cause of preventable blindness, and it's caused by this precipitation of proteins in the lens. Risk factors are older age, steroids, diabetes, and the symptoms are they'll get blurring, kind of hazy vision, particularly sensitive to bright light. So a lot of them kind of describe seeing halos around light as well, and find it particularly hard to drive at night. Affects both the near and the distance vision equally, because it's kind of within the lens, and their fields will be normal, because it's just within the whole lens, it's not a particular area. And the treatment is surgery. So if someone's got severe cataracts, they just need a referral, because that's the main treatment. I'm sure probably people have seen cataracts before, but this is just an image of what they look like. And once you know what they look like, you'll see kind of how common they are, because so many, basically if you go onto any geriatric ward, most of them will have cataracts. It's really common. So chronic glaucoma.
Yeah. I was wondering what the like almost pathophysiology behind, or the reason why there's the dazzling of the bright light. Is it
I think it's to do with kind of refraction within the lens. This could be wrong, but I think it's to do with the proteins in the lens just distort the light rays. and are going to make them kind of scatter more than they should do. I think that's how I've made it make sense in my head, but I don't know for certain. So moving on to chronic glaucoma. So chronic glaucoma is kind of a degeneration of the retinal ganglion cells. It's screened for by opticians very regularly, and the field loss can mean that patients can't drive, so DVLA need to be told. Key features, so you have this raised intraocular pressure. In glaucoma, it's typically above 25, and you'll get changes to the shape of the optic disc. So it's usually kind of the optic disc is kind of bigger than it should be because you've lost the kind of retinal cells around the edge, and you get visual field defects. So your central field is usually spared until quite late. It's more your peripheral fields that go. And in terms of risk factors, if you're of an older age, African and Caribbean people tend to get it more commonly. Again, if you're short-sighted, and if you've got a raised intraocular pressure for any other reason. So the treatment for chronic glaucoma will slow down the progression, but it doesn't reverse any damage that's already done. And the kind of main target of the treatment is to lower the intraocular pressure. So you can give prostaglandin analog drops. So most common of them is latanoprost, and that increases the outflow of the aqueous fluid. Or you can give beta blocker drops like timolol, and that reduces the production of the aqueous fluid. And if drops don't work, then you can do surgery. So next, SBA. Which two of these are common side effects of stop that pull, of 1 second. There I go. Which two of these are common side effects of prostaglandin analog eye drops, such as latanoprost? So A, shorter eyelashes, B, longer eyelashes, C, darkened eyelashes, D, lightened iris, and E, darkened iris. So two of them are right. We'll do 5 more seconds. Ooh, I can see someone posted in the chat as well. There is a link. It's probably a bit late now. There's only one question, but I'll look at your. They flash up when you vote, so I can see it. I'm going to stop the poll now. So whoever answered in the chat, you're right. B is one of them. So B and E. So you get longer eyelashes and a darkened, so hyperpigmented iris is the other way they sometimes phrase it. So they're quite nice side effects, really. Of the ones, they're probably the ones that you'd want. And straight into another SBA. So an 82-year-old gentleman comes to clinic complaining that his vision has suddenly deteriorated. His left eye is worse than the right, and he reports it started getting worse a few days ago. On Amsler grid, he reports that he sees wavy lines. What's the likely diagnosis? So is it A, dry macular degeneration, B, cataracts, C, diabetic retinopathy, D, a visual migraine, or E, wet macular degeneration? Give you another 5 seconds. Right. So the answer is E. So it's wet macular degeneration. So the key things in the question that point to wet macular degeneration are that it's got worse suddenly, and he's seeing wavy lines. So they're kind of two things that should kind of be red flags for wet macular degeneration. So macular degeneration in general is a degenerative disease of the central part of the retina, which is the macula, and that's the part that's involved in your central vision. And it usually occurs in people over 60. Smoking is a big risk factor for it. And it affects people's ability to read, affects their ability to recognise faces. You can't read kind of text at a distance. So it really impacts people's lives a lot, because if you can imagine that, you know, people go from not being able to clearly see kind of the facial expressions of their loved ones, or like reading is massive. Anything that you're trying to focus on is what they won't be able to see. So it's quite horrible. It doesn't affect their peripheral vision though. And you have two different types. So you've got your dry and your wet. People tend to see them as distinct, but dry can lead to wet. And kind of dry is just where you get this gradual loss in the cells over many years, and it's kind of really slow progression. And there's no treatment for it. It's just kind of supportive. You can ask them to increase their dietary kind of things like luteins and zeaxanthins, apparently. So apparently lots of spinach and kale can get them to take some supplements as well. And wet macular degeneration is caused by a leakage of kind of edema or kind of blood from capillaries under the retina. So you get this sudden change, and because the layers of the retina are being distorted by this excess fluid and edema, it means that kind of the straight lines then look blurry. And on the right, I've got a picture of what an Amsler grid is. So it's literally just a grid of lots of straight lines, and you can just ask them kind of what if they tell you that any of the lines look blurry, then look wavy even, sorry, then always worry about wet degeneration, and they need to be referred on for anti-VEGF injections. So diabetic retinopathy is the commonest cause of blindness in working age people in the UK. And risk factors, so if they have poor diabetic control, if they're of an older age, if they have poor blood pressure control, and diabetes has kind of the two main effects on the capillaries. So it makes them become leaky, and it also occludes them. So if you get kind of leaky capillaries, then you get hemorrhages, and you also get edema, and then macular edema can be treated with anti-VEGF injections. There are kind of a couple of features it's kind of one of those things just to know that they're associated with diabetic retinopathy. So you get cotton wool spots, and that's caused of occlusion of the capillaries. You can get widespread occlusion of the capillaries, and that kind of causes a global ischemia, so the retina can look kind of pale. And because of the ischemia caused by the occlusions, the eye tries to compensate by making loads of new vessels, which is actually kind of not that helpful, because these new vessels, they can bleed, and sometimes they bleed into the vitreous, so then they can cause vitreous hemorrhage. Sometimes they can kind of fibrose and cause retinal detachments as well. And sometimes they can also grow on the iris, and they can block the trabecular meshwork, so they can cause glaucoma. So it's kind of diabetic retinopathy then leads to loads of other conditions. And in terms of treatment, you can kind of laser the whole retina, which kind of gets rid of all the ischemic tissue, and that kind of gets rid of the drive to produce new vessels. All diabetic people are screened annually for retinopathy, and obviously if you can improve their diabetic control, that's going to have a big effect as well. So an overview of everything well, not everything we've gone through today, but most stuff we've gone through, an overview of ophthalmology for medical school in general. These are all the conditions that are in the kind of medical licensing exam, and I put little stars by the ones that I think are just really important not to miss. So in acute red eyes, we've got conjunctivitis, keratitis, uveitis, acute glaucoma, periorbital and orbital cellulitis, and you've got scleritis and episcleritis as well. In acute loss of vision, never forget stroke. We didn't mention it today, but that's something to always consider. GCA, central retinal, arterial and venous occlusions, vitreous hemorrhage and retinal detachment. And then chronic, you've got the 4 that we've just gone through. And there are a couple of other eye conditions as well. So blepharitis, chalaisons and styes as well. They're quite common in primary care. So probably worth just kind of quickly knowing a little bit about. But that is everything from me today. If you could scan the QR code, that would be really helpful, and just give some feedback, both about the session today and just about the sessions in general. It's really nice for us to kind of know how it's going and what we can do to improve. But does anyone have any questions as well?